Sending you the YouTube link of this discussion as well as our previous discussions if that is helpful, maybe tomorrow. And our panelists will also share some of the resources with us so that they will be with you to refer if you need to. So first of all, my name is Dr. Prasad Dandekar. I'm a radiation oncologist. I'm based in Mumbai. I work for the Sir H.N. Reliance Foundation Hospital. With me today, we have two panelists, two speakers. In fact, Dr. Indraneel Malik is the consultant radiation oncologist at Tata Medical Center in Calcutta. And Indraneel actually needs no introduction. Most of you would know him if you have attended any good conference. In Indraneel's talk is definitely there, and it's one talk that we definitely don't want to miss. Dr. Choi is a associate professor in MD Anderson, and he specializes in prostate cancer, and he uses proton beam as well as photon. So we will have a very rich discussion with both of them today on prostate cancer and hyperfractionation and use of proton beam in prostate cancer. And it's a very relevant discussion, hyperfractionation from the point of view of COVID, and as well as moving forward, how do we improve our outcomes? And proton beam also very much, because we know now we have a proton beam center in India. So which patients would benefit from referring to proton beam? So it's a very relevant topic. So over to Dr. Indraneel. And so we will, one request is, if you have any questions, and I hope you have a lot of questions, please post them in the Q&A section and not in the chat section, so that we take all those questions after both the talks are over. And let's start with Dr. Indraneel.
Thanks, Prasad. I'm just going to stop my video and share my screen.
Yeah, I think all three of us will go off video so that the screen, is easier to see.
I hope all of you can see my screen, Prasad.
Yes, we can see. Participants, please give us a hands up or thumbs up if you can see and hear all three of us. Okay, excellent. Thank you very much.
Okay, great. So very, very good morning to all of you. It's Saturday evening, and I'm sure you have better use of your time. But let's discuss some hyperfractionated radiotherapy for prostate cancer. Now, Prasad's series has been an absolute pleasure. I've attended, if not all, but parts of the previous ones, and it really gives us a dimension into how we should approach our practice. And he picks these topics which are relevant at the moment because of the COVID-19 situation. So I'm going to talk about hyperfractionated radiotherapy for prostate cancer, an evidence-based implementation. The question is it just for the pandemic, or is it ready for routine clinical practice? Now, the questions for the evening, as far as I am concerned, is what is the rationale for hyperfractionation? A brief introduction, because I'm pretty sure all of you know, but just if there are students here, just a quick recap of the biological and the socioeconomic rationale for it. How it fits into the pattern of radiotherapy at the time of COVID-19. What is the evidence for moderate and ultra hyperfractionation? And we are going to go through all of this in the context of our experience at Tata Medical Center in Kolkata in developing a program for hyperfractionation since 2011. So what is hyperfractionation all about, really? Now, we know that the traditional way of treating prostate cancer is with 2-Draper fraction, and it's usually about 39 fractions over nearly 8 weeks. The question that hyperfractionation asks us is whether using the unique radiobiological properties of prostate cancer, can we say that this is the same as giving 3-Draper fraction and reducing the number of treatments to 4 weeks, and further going forward reducing it even further to 7 to 9-Draper fraction, giving 5 fractions either alternate days over 2 weeks or once a week over 4 plus 1 days, 4 weeks and 1 day. Now the basis for this is the linear quadratic equation, and we know that really the biological property of the cancer that we are trying to treat and the organs at risk that we are trying to spare rests on the alpha beta ratio. And just for the students, you know that for the tumors, we assume that the alpha beta is 10 and the normal tissue alpha beta is 3. And if we assume that, then the best balance between effect and toxicity is when the dose per fractionation would be 1.8 to 2 gray. But we know from biological studies that some cancers, like prostate cancer, are different. Here, the alpha beta is much lower for the cancer. It is in fact close to 1.5, which is less than normal tissues. And that, really changes the way we look at how we fractionate radiotherapy in prostate cancer. Now, this is hardly a new paradigm. Using data from brachytherapy and high-dose brachytherapy, radiobiological experts have, for the last nearly 2 decades, been looking at the alpha beta of prostate cancer. And in addition to radiobiological, clinical data from high-dose brachytherapy compared to external beam radiotherapy and lab studies, all of these papers for the last, in the first decade of the 2000s, really showed that the alpha beta ratio of prostate cancer is probably something close to 1.5. Now, the confidence intervals of some of these analyses, these models are wide, but if you look at the point estimate, it's pretty close to 1.5 in most of the analyses. And what does that mean in terms of fractionation? Now look at the 2 red lines. If you want to keep the dose to the prostate cancer at around 80 gray, 78, 80 gray, and if you assume that the alpha beta of prostate cancer is 10 and you want to keep the EQD2 at around 80 gray, and then you give high doses per fraction, the dose to the normal tissues increases like this. It goes above 100 gray EQD2. But if the alpha beta ratio of prostate cancer is 1.5, then exactly the opposite happens, because it's now less than the normal tissues. So if you increase the dose per fraction and keep the dose to the tumor at around 80, 85 gray, the dose to the normal tissue actually reduces. And this gives us a brilliant opportunity to reduce the number of fractions in prostate cancer without causing more harm and perhaps improving the effect on the cancer itself. So why are we discussing this today? We are discussing this because we are faced with a very unique situation at the moment. The COVID-19 scenario in most countries is pretty bleak. And we have to look at how we can use evidence-based fractionation in order to reduce the number of visits that a patient has to come to the hospital for treatment. Now, this is a consensus guideline or recommendation from several experts across the Atlantic, in fact, from the US and from Europe. And these recommendations in response to COVID-19 basically look at 4 paradigms: making remote visits, avoiding radiation when it can be avoided without harming the patient, deferring radiation when it can be deferred, because we know that in prostate cancer, the disease is slightly slow growing and there's androgen deprivation therapy, which can be used to defer radiation or to shorten radiation. And this is what we're going to discuss today by using shorter fractionation schedules. So if you look at the summary of the recommendations for curative radiotherapy, if you look at the screen, you'll see that for the very low risk, there's no radiotherapy. For the favorable intermediate risk, they are saying delay until safe. But what is interesting is over here, in the unfavorable intermediate risk, high risk, and node positive, the recommendations say that for the first 2, they would prefer 5 fractions, and whereas for the rest, 20 fractions is what they recommend. And whenever possible, to use androgen deprivation therapy to delay the start of radiotherapy as long as it is clinically safe. Even when you look at the adjuvant or salvage setting, they're recommending 20 fraction radiotherapy. So that's the real big shift in the way of thinking when we look at prostate cancer. So the question that we have this evening is, should we hypofractionate in India? there are four sub-questions to this. Is there a need to hyperfractionate? Is there enough evidence of hyperfractionation in the patient population that we see in India, the more locally advanced, high-risk, node-positive patients? Is there enough experience in India in moderate and ultra-hyperfractionation? And the real question is hyperfractionation only for the pandemic, or is it ready for routine clinical practice? Now, to answer this question, we have to really see where do our patients come from. Now, this is a map of patients who visit our hospital for prostate cancer radiotherapy. So these are mapped according to their addresses. The blue dot over here is our hospital in one corner of town. And this is really the city of Kolkata. And as you can see, there are lots of patients who come not from distances that are reasonably far away. These are 2, 3, 4 hours from the hospital. And making 39 visits to the hospital is not going to be something very comfortable. If we zoom out a little bit, we see that patients often come to hospitals from much further, in fact. And this is the state of West Bengal, and this is Bihar and Jharkhand, and this is Bangladesh. And you can see that the patients really are traveling long distances, and therefore it becomes really relevant to say that, you know, patients, if we can reduce the number of hospital visits, if we can reduce the cost of stay and transport, reduce the cost of treatment, because we are actually delivering less number of treatments. And from the hospital perspective, if we can use less resources, then more patients can be treated using the same resources. And therefore, hyperfractionation is not really a Western concept. It is really extremely relevant for a country like India. But to go there, we also have to ask, is there enough clinical evidence for hyperfractionation? And we'll start with moderate hyperfractionation. Now, if you look at the timeline, over the last decade or so, there have been several randomized control trials that have been reported. These are 6 randomized control trials, starting with the Italian study, then the CHIP safety data, the Fox-Chase study, the RTOG, CHIP, and HYPRO studies, and the PROPHET study, which really have set the benchmark for moderate hyperfractionation. And I'm going to look at these studies as a summary, because in order to make it brief. Now, these studies used these doses of standard fractionation and moderate hyperfractionation. Now, the question in my mind is, have they treated enough patients in the risk groups that we see in India? And this is usually the high risk group. So if you look at these studies, we see that patients are spread across all risk groups. So there are low risk patients, intermediate risk patients, high risk patients, and there are several patients who are the high grade patients, at least in group 4 and 5. So if you want to summarize, there are nearly 7,000 patients in these studies, and about 1,250 patients of high risk, and about 500 patients with high grade Gleason grade cancers. And what do these studies really show? If you look at across the studies, they basically show that the results are more or less the same between moderate hyperfractionation and standard fractionation. The first study, the Italian study with high-risk patients, actually had better results with moderate hyperfractionation. And the CHIP study, the 57 gray in 19 fraction arm, could not be proved to be non-inferior. But if you look at the other studies and overall, we find that moderate hyperfractionation now has evidence from 6 randomized control trials to show that it is non-inferior to at least to standard fractionation. But the question doesn't end there. I mean, is it safe? So if you look at those studies and if you look at the toxicities, and basically I've summarized the grade 2 GI and GU toxicities, you again see that the side effect rates are generally similar. So we're looking at figures in the range of 10 to 17%, approximately 10 to 18%. And apart from the RTOG 0415 study, which showed slightly worse side effects in the hyperfractionated arm, and the PROPHET study, which showed slightly better side effects in the GI group in the hyperfractionation arm, the side effect profile is also generally similar. Now, it has to be remembered, if you want to dig really deep, that these studies were not all designed for similarity. So some were expecting that hyperfractionation will improve the results. Some were expecting that hyperfractionation will reduce the side effects. Now, that didn't really happen. But what these studies do show overall is that hyperfractionation is more or less the same. So what we now can conclude is that reducing the number of fractions to around 20, 27, or 28 is safe and effective. Now, what about evidence from India? What is the experience that you have in India? Now, there are some centers which started hyperfractionation pretty early. There's a lot of experience from Tata Memorial in Mumbai. I'm going to talk about our experience in Tata Medical Center in Kolkata in moderate hyperfractionation. Now, we started moderate hyperfractionation the day we started our hospital, because we realized at that point from the Italian study that had been published in 2010 that this was something that we should look at, given the fact that we were expecting that there would be a resource constraint soon, because the number of patients who were starting to come to our hospital right from day one. And just as when the CHIP safety data got published, we started our moderate hyperfractionation protocol. So far, we have treated 630 patients with moderate hyperfractionation between May 2011 to December 2019. The first 18 patients we started conservatively, 65 grain 25 fractions over 5 weeks. But as soon as the CHIP safety data got published of 1620, we shifted to the 1620 fractionation. In order to get there, we had to take several steps. We had to first of all, find out what our image guidance protocol should be. So we actually did a small study of the first, 30 patients who with daily imaging, and we found we simulated a scenario whether we could reduce the number of imaging to less than daily imaging, and we found that could not be done, and daily imaging became our standard treatment. Then we had to decide how do we set our dose constraints. So instead of actually copying from another trial protocol, we thought that we should actually develop one ourselves. So we looked at the Quantec constraints for the doses. We found, corresponding doses at 3 gray per fraction for the rectum and bladder, and we reduced our constraint to lower approximately 60% of the Quantec constraints just to make sure that we were safe. And this is what we achieved in the first 100 odd patients, and we found that we could easily achieve these goals. We analyzed our acute toxicity and the dosimetric correlates, because we had to wait for the late toxicity. And our fellow then and now my colleague Moses did this beautiful analysis of acute toxicity and its dosimetric correlates, and we found that the acute grade 2 toxicity and the grade 2 genitourinary toxicity were more or less as was being reported elsewhere. There was no grade 3 or grade 4 toxicity that we found. And we could find some absolute dose volume correlates that were predicting better than relative dose volume correlates for rectal and bladder toxicity. So over a period of time, these are our current dose volume constraints. This is the target objectives, and these are our rectal and bladder objectives, and we have bowel bag, femoral head, penile bulb, and external genitalia objectives as well, which I'm happy to share with you. Now, of course, everything sounds rosy when you're treating high-risk prostate cancer, because the androgen deprivation therapy is really helping you out, but we really need long-term results. So we analyzed the first 100 patients with high-risk disease, and with a median follow-up of 5 years, our biochemical recurrence-free survival was 85% at 3 years, and 79% at 5 years. We found that it's the Gleason score which really determines the outcomes. And we also found that the duration of androgen deprivation therapy, because we are really dealing with a very high risk group. So orchidectomy patients had better outcomes than medical castration patients, and that is mainly biochemical control. We have to look at a bit longer to see whether it translates into overall survival. Our toxicity rates were pretty reasonably low. The GI toxicity, as far as genitourinary toxicity was concerned, we found that a prior history of a TURP predicted for worse toxicity outcomes. Now, this I don't believe is typical only for hyperfractionated radiotherapy. I would presume that this would be the same in standard fractionation radiotherapy as well. Now, we do get a pretty high number of node-positive patients as well. So we looked at moderate hyperfractionation radiotherapy results in our node-positive prostate cancer cohort. And so these are the first 61 node-positive cases, followed up for 48 months. So biochemical failure happened in about 15 of them. They were mainly distant metastases with local regional failures only in 4 of them. And the 4-year biochemical control rate was 77.5%, and overall survival was 91%. So this is really encouraging, because for about a fourth or a third of your patients who would typically be characterized as metastatic disease, if you're getting a biochemical control of close to 80% at 4 years, that's something to really look forward to. We also found that patients who had residual enlarged nodes after initial ADT, so these are the patients who had bigger nodes, had worse biochemical control. So perhaps it's the volume of disease, the volume of nodal disease did have an impact on overall outcome. What about ultra hypofractionated radiotherapy, also known as stereotactic radiotherapy? This is an interesting, nomenclature, because while stereotactic radiotherapy really started out on units like the CyberKnife and could truly be called stereotactic radiotherapy, it really came into widespread use using LINAC-based IMRT. So I think more people prefer to call it ultra hypofractionated radiotherapy at the moment. So the initial phase 1 and phase 2 studies showed that mostly use 7 to 7.5 gray per fraction. Dose escalation up to 10 gray has been tried, and most centers started out with low-risk patients. Most initial studies were with CyberKnife, but now there's widespread use on LINAC-based VMAT and IMRT. In 2013, a pooled cohort of 1,100 patients enrolled in phase 2 studies was reported by Chris King and colleagues, and they showed really, really encouraging results. In low, intermediate, and a few high-risk patients that stereotactic radiotherapy had been tried with, and they found no impact on ADT on the control in these patients. The question then became whether it would be daily treatment or alternate days or weekly treatment. Now, although the initial protocol started out with daily treatment, they found that compared to alternate day treatments, the slightly higher incidence of overall late GI and GU side effects. Alternate day treatments are therefore now the most commonly used schedule, although there are several small studies with weekly fractionation as well, originating mainly from Canada. Now, what about our experience with ultra hyperfractionated radiotherapy? So as soon as the SBRT pooled studies came out, we decided that we really needed to try ultra hyperfractionated radiotherapy, because these studies were looking at mainly the low and intermediate risk cohort, whereas our patient population was mainly high risk. So we started our protocol known as the SHORT protocol in early 2014, and it was meant to be a phase 1, phase 2 study. So we, the short course hyperfractionated once weekly radiotherapy, that's the full form of the SHORT protocol. We registered this as a phase 1, phase 2 study. And our eligibility criteria was localized prostate cancer, all risk groups, as long as the PSA was less than 60, and that was just an arbitrary cutoff. Treatment was 35 gray in 5 fractions. We chose a once weekly treatment regimen because we wanted to be really safe. And data at that point in 2014, there were quite a few Canadian studies which were using once weekly fractionation. What was different was that we chose to give elective nodal RT in high-risk patients at 25 gray 5 fractions. That was when we realized that other studies in Canada starting at the same time happened to use the same fractionation for elective nodal radiotherapy when they were looking at high-risk cohorts. We used IMRT RapidArc CBCT before and after treatment, and our primary outcome in this study was acute toxicity with biochemical control, late toxicity, and quality of life as secondary outcomes. So this is a diagram of the phase 1/2 study that we ran. We looked at acute toxicity. We looked at the quality of life scores. We looked at the IPSS scores, and androgen deprivation therapy was used by risk group intermediate risk 6 months and high risk 24 months. Again, just as we had done for moderate hyperfractionation, we tweaked the quantic constraints, lowered them, and derived our own dose constraints to the OARs. Again, I'm very happy to share these dose constraints with you if it helps you develop your own program. Now, there are a few important characteristics of our ultra hyperfractionated program. We use prostate and elective nodal RT for high-risk patients. We use VMAT treatment planning with in-house constraints. We use once-weekly fractionation. And we did not use implanted fiducials, but did our image guidance with daily CBCT before and after treatment. Now, the reason why we did all this was we wanted to develop a program that was easy to continue and which could be replicated in other centers if our program was successful. And of course, safety was something that was very high on our agenda, which is why we chose the once-weekly fractionation. Now, once we started, several other studies on ultra hyperfractionated radiotherapy came up, and the first, one of the really important ones to know is the dose escalation phase 1 study, phase 1/2 study by Timmerman and colleagues, and they found that up to 9 gray was safe, but 10 gray into 5 fractions resulted in very high rates of grade 3 and 4 GI toxicity, including several permanent colostomies. And therefore 10 gray into 5 fraction is a bit too high, we know. The hypo-RTPC study reported in 2019, which is not really a stereotactic radiotherapy study, but an ultra hyperfractionation study, which used 42.7 gray in 7 fractions, 3 fractions a week. There was no difference in the estimated failure-free survival at 5 years, which was 84% in both groups, and no difference in physician-reported acute or late toxicities, but slightly higher patient-reported acute toxicities in ultra-hyperfractionated, but not late toxicity. In 2019, again, the acute toxicity results of the PACE-B randomized control trial got published. This is a large randomized control trial in the UK, looking at low and favorable intermediate risk patients, comparing 78 gray in 39 fractions or 62 in 20 versus 36.25 in 5 fractions. And they found exactly same rates of acute toxicity between the two groups. So what happened to our study? I mean, these studies were published in 2019, and we published our study soon enough. And what we found, this is our results which got published earlier this year. And among the 30 patients in this phase 1/2 study, most of them were high risk. About 2/3 were high risk patients, high or very high risk. We could easily meet our dose constraints that we had set in our study. The acute and late toxicities were quite low. If you look at the acute toxicities, they were high. If you look at the GI, rectal acute toxicity, there was no grade 2 or grade 3 toxicity with the once-weekly fractionation. There was just 1 grade 2 toxicity in the urinary domain. And if you look at late toxicities, those were small numbers as well. We analyzed prospectively the quality of life, and the only detriment we found was an end of radiotherapy, temporary worsening of the urinary symptoms. But there was no other significant worsening of any other symptoms up to 12 months. And the IPSS scores, because of the unique nature of prostate cancer in India, there are plenty of people with lower urinary tract symptoms. So these are patients more than 12 IPSS score to start with, the ones in red. And over a course of 6 months, we found that there was at the end of radiotherapy, there was a bit of worsening, but generally these scores come back down close to baseline. In terms of disease control, with a median follow-up of 3.5 years, there was one patient who had a biochemical failure at 10 months with bone metastases. At 3 years, our biochemical control and clinical control is 96.7% and around 88% at 4 years. There was one death unrelated to prostate cancer with a 4-year overall survival of 96.7%. Now, if you look at our toxicity comparison with other studies, there are quite a few which have done once-weekly radiotherapy, and these are pretty good. These are our late toxicity reports, and if you compare with others, they are pretty more or less the same. So we have been able to replicate in a high-risk cohort what other studies have done, mainly in low-risk patients. While our study was the only prospective study, there is initial, published retrospective evidence from TMH in Mumbai on SBRT in 68 patients of high risk, very high risk, and node positive cancers. With a short median follow-up, they found that the acute toxicity rates were low, so it's well tolerated, and the initial, biochemical control was very encouraging. Now, coming to the, back to the alternate day versus once weekly regimen, there is a randomized control trial, again led in Canada, in low and intermediate risk patients, comparing once weekly versus alternate days with a toxicity primary endpoint. They found that once weekly fractionation had superior acute bowel QOL, so the acute toxicity rates were slightly better in the once weekly arm. There was no difference in the late grade 3 toxicities between the arms, and no significant difference in the 5-year biochemical control. So the question really is that in the high risk patients, can we assume that ultra hyperfractionated is the standard of care? Well, not yet. There's no data yet. So in Tata Memorial Hospital, Dr. Vedang started the PRIME trial, which is randomizing patients to moderate hyperfractionation versus ultra hyperfractionation, and we joined the study with our dose fractionation. So it's basically using 2 equivalent moderate hyperfractionation schedules and 2 ultra hyperfractionation schedules. They're using alternate days. We are using once a week, so that we can actually have a comparison also between the scheduling of the ultra hyperfractionated radiotherapy. So if I can conclude, hyperfractionated radiotherapy has a strong radiobiological and clinical basis. Moderate hyperfractionation, of course, can be considered standard of care in all risk groups because a substantial number of patients have been treated in randomized controlled trials. And there is evidence of safety and efficacy in node positive patients in our series and a few other published series around the world. As far as ultra hyperfractionation or SBRT is concerned, there is evidence of safety and efficacy in phase 2 studies. In the PACE-B study, we know that acute toxicity rates are equivalent. We know from our data that in phase 2 safety and efficacy data in high risk in a small number of patients is quite encouraging. And there's a randomized control trial ongoing in India in high risk patients and node positive patients, which we are all very excited about. So ultra hyperfractionation there's enough evidence now that it can be used during the pandemic. And once the results of the PACE-B and the PRIME trial come out, it may well become a standard of care in the future. So thank you very much. I'd like to take this opportunity to thank some of my colleagues, Dr. Moses Arun Singh, who's my colleague and shares a lot of responsibility in prostate cancer treatment. Several fellows who are working in prostate cancer projects, Shaurav, Saheli, Samart, our excellent physics and tech team, and all my consultant colleagues who work together with me. Thank you very much.
Thank you very much, Dr. Indranil, for that wonderful talk. We will start with Dr. Choi, and once both the talks are done, we'll take the questions. We already have a lot of very interesting questions coming up for Dr. Indranil. So please hang on and we'll take them at the end. Welcome, Dr. Choi.
Oh, thank you very much. Can you hear me okay and see my screen?
Yes, we can hear you. I mean, I can hear you. Can the participants please give us a thumbs up if you can hear? Yes, perfect. Yeah.
Perfect. I'll get started. So thanks for the invitation to talk about proton therapy for the treatment of prostate cancer. So maybe so I can get this too. So I don't have any financial disclosures. And so what I wanted to sort of talk about today was introduce the concept and the physics of proton therapy, why we use protons, especially in the treatment of prostate cancer, talk about the actual data that's been published to date in terms of conventional fractionation, hypofractionation, and I guess probably for you, the audience, probably the one you really want to know is IMRT versus protons. Really, is proton therapy better than IMRT? So kind of go over those data that's been sort of published to date. I'm going to talk about some of the recent advances and future directions that we're taking here at MD Anderson Cancer Center for proton therapy, and then conclusions. So at least in the US, prostate cancer is the most common non-cutaneous cancer in men. And in this year, there's estimated to be about 190,000 cases, which is actually higher than the year before. It is the second most common cause of cancer death in men in the US, and there were 33,000 deaths estimated this year. But if you look at the actual cure rate of prostate cancer, it's actually quite good. In fact, the 5-year relative survival, so comparing patients who don't have prostate cancer, there's only about a 2% cancer death from prostate cancer at 5 years. That means that when we treat patients with prostate cancer, we definitely need to make sure that we not only cure the patient, but really minimize the risk of side effects. I think this is pretty old data. This is actually from 2008, published by Dr. Kuban, one of my colleagues, showing that when you do treat prostate cancer, the dose does make a difference. So the higher the dose, the higher the chance of curing the cancer. The problem is that there is a price to be paid for that higher cure of more side effects. So this is looking at the randomized trial at MD Anderson Cancer Center between 70 versus 78 gray. As you can see from this figure, the patients who got 70 gray had a higher chance of not having side effects from the radiation therapy in terms of rectal complications. So once again, having a higher dose more than double the risk of having rectal complications. And that actually was dose dependent. So if you're V70 or the volume of the rectum getting 70 gray or more was 25% or more, there's actually a tripling of the rectal toxicity. So we actually know that the actual patients who get more dose than normal tissues do worse in terms of side effects. So because of that, I think the concept of using proton therapy was sort of discussed and sort of actualized at MD Anderson. So I suspect you've seen this figure before. This is the dose deposition characteristics of different types of radiation. The yellow is X-ray therapy, and the red is protons. As you probably already know, with X-rays, you have some dose given at the surface of the patient. There reaches what's known as a Dmax, or the maximum point, and then the dose will sort of decay exponentially from that point. With proton therapy, there is some dose given at the surface of the skin, but it's actually a pretty low dose. The entrance dose is quite low. Then we'll give some sort of constant dose until it hits what's known as a Bragg peak, where it gives all of its dose, and therefore we'll stop at that location or that point. And from then on, there'll be no exit dose. So that once again, beyond that Bragg peak, there won't be any more scatter dose beyond that point. That being said, this Bragg peak is too narrow for treatment of actual cancer. So we have to do something called a spread out Bragg peak, where you actually need to sort of widen the Bragg peak so that the area of tumor is getting the full dose of radiation. What that really does is that does increase that superficial, the dose before the actual tumor. So it won't be as nice as this one, where in this case, the superficial dose is 30, or proximal dose is 30% of the full dose. And this is a different graphical representation of, once again, the dose between X-ray therapy. So once again, these color wash shows dose with the yellow being the 100%. As you can see, once again, the 100% is being deposited close to the surface of the skin, and there's exponential decay. And here with protons, there's some dose being given, but pretty much all the dose is given at the area of the tumor, and there is no exit dose beyond that point. We do have different types of proton therapy. This is what's known as passively scattered proton therapy. We use something called a range modulator wheel, as well as a brass aperture. In fact, this is what you see pictures of in textbooks, where we use this brass aperture to shape the shape of the proton beam to the shape of the prostate. So this is actually a brass aperture for one of my patients. And this actually is the actual plan, where once again, you can see the prostate in sort of the blue, and this light blue includes both the proximal seminal vesicle and the prostate. And once again, this brass aperture shapes the radiation dose to the shape of the prostate. We also use something called tissue compensators to sort of normalize the dose. Proton therapy is very sensitive to changes in density as it goes through tissues, which means that in the pelvis, where there is different amounts of bone, depending on where the prostate is located, different parts of the treatment could sort of lead to different doses. So for instance, here, where there's a lot of bone in this sort of pathway, there will be less dose given at the we'll call a distal edge of the prostate, compared to, let's say, this area where there's much less bone. So this tissue compensator tends to compensate for that changes in, or differences in, the amount of bone in the pathway of the protons. So it's almost like a negative image of the patient's bone density. So once again, this will sort of even out the dose at the distal edge of the prostate. So this is actually one of our patients. getting proton beam. The nice thing about proton therapy is that unlike IMRT, we tend to use only 2 beams, usually 1 from each side. In fact, Loma Linda only treats 1 beam per day. So they kind of alternate right side, left side. And this sort of beam could be delivered in less than a minute. So the actual dose delivery is quite fast. And so I think that allows for hopefully the patient's prostate to not move during that short time during the actual treatment. Also allows us to sort of treat more patients throughout the day in terms of patient throughput. The newer technology for proton therapy is called pencil beam or scanning beam. So what you sort of saw was kind of a 3D conformal equivalent of protons. And this is more like IMRT. So what we do is now is that we actually send in a much narrower beam. So whether the passive scatter beam works, that you actually create a larger square shaped beam. For us, it's either 10 by 10 centimeters to 25 by 25 centimeters. And that square beam is then shaped to the shape of the prostate using those apertures that you saw. With pencil beam, we actually send in a very narrow beam, usually 0.5 to 1 centimeter in diameter. And this beam can be steered with electromagnets because protons are positively charged. And then we're able to then sort of selectively deposit this sort of what we call spot onto the patient's tumor target, or in this case, the prostate. So once again, it's almost like spray painting where you can sort of see this one spot of dose. And we're able to then sort of paint that slowly over the actual sort of shape of the tumor. And in terms of, once again, this shows that you can sort of steer that with electromagnets. And we're able to deposit the dose to the actual shape of the tumor, no matter what that shape is. And I think the advantage of this pencil beam are actually quite a lot compared to passive scatter. In fact, I'm happy to say that the Proton Center in India, in Chennai, actually has all scanning beam capabilities. So it's not actually passive scatter anymore. In fact, all the new centers in the last 2 years and going forward, pretty much they all have scanning beam. They don't have passive scatter anymore. Now, the advantage of pencil beam is, once again, improved conformality. So it can shape the dose around curved structures. Also, as you remember, you have those apertures and compensators, which had to be made physically. We usually do that on site. We have a machine shop that actually makes those devices. So the patients with pencil beam don't need to have those specific devices made or stored, which then makes that easier for us to do more beam angles and more conformal treatments. Also, because of the hardware can cause neutrons, so that's actually the last one, there's actually fewer neutron contamination, which should lead to less effect on medical devices like pacemakers, as well as decreased risk of secondary cancers. You can also do better proximal tissue sparing, and then we can also do intensity modulated proton therapy with SIB or simultaneous integrated boost if you wanted to. So we've been doing a lot more recently with either positive lymph nodes or especially with post-operative patients who have an actually MRI visible tumor in the prostate fossa. We have been giving a higher dose per day to those sort of gross areas of disease using proton therapy. This is actually a dissymmetric difference between passive scatter beam and scanning beam. So on the left is the 3D conformal or passive scatter. As you can see, the red is so this color wash shows that the dose of radiation can be shaped the shape of the prostate, which is in red, but it's kind of wide. As you can see, this is actually the prostate right here. And this red is much larger than the actual shape of the prostate. On this side is the scanning beam or pencil beam. As you can see, the red is now shaped much more like the prostate. And also it's a little bit more subtle, but the actual dose given to the sort of pelvic bony structures is less, as sort of denoted by the cooler colors on the color wash map. This is actually one of my patients. And so one of the advantages of really pencil beam is that once in a while you get these weird shaped prostates. In this case, the patient had a much more kind of a larger right lobe of the prostate that came over to the right side posteriorly. And so once again, you have this sort of area that needs to be covered. And once again, with pencil beam, we're able to spare the rectum by shaping the dose around that lobe of the prostate. That's very hard to do with passive scatter. I have to admit, this is the comparison between a standard IMRT plan that we have at MD Anderson versus the protons. And we only need to use 2 fields versus we used to use 8 angles, now we use VMAT, but in the end, you need a far fewer number of beams with protons than with IMRT. And once again, if you look at the area that's getting kind of the high dose, the red, they look very similar to the shape of the prostate, but all this sort of scatter dose given to the rest of the pelvis is completely avoided with the proton therapy. To be honest, though, I think the biggest benefit that you'll see, though, is in patients who get treated for their pelvic lymph nodes. So I think we're doing more and more of these treatments where I think patients are coming with either positive lymph nodes, or I think with better systemic therapy, they're actually sort of failing later with lymph node recurrences. I think so. We're treating a lot more pelvic lymph nodes than we used to. And I think for that, the proton therapy is really great. So once again, on the left is the IMPT or proton plan treating the pelvic lymph nodes. This actually was a post-op patient, so this is the actual fossa. But as you can see, with this type of proton plan, the dose comes from the back and from the sides. So all this area in the front where the bladder and the small bowel is completely spare from the radiation therapy. This is actually our comparative IMRT plan. Once again, you are giving dose to the lymph nodes and the fossa, but all this area is getting the actual dose. In fact, this is a subtraction image of sort of the or subtraction dose image where the actual colors is what the dose is given extra with the IMRT plan compared to the proton plan. As you can see, there's a lot more dose being given to the anterior structures like the bladder and the small bowel using the IMRT. So I think, once again, as we treat more patients with either lymph node disease or high-risk disease, I think the proton therapy would definitely have more benefit for the patients that we treat. In terms of the actual results of the proton therapy, I think, unfortunately, we haven't been as active in terms of publishing proton therapy data as we should be. I think that, unfortunately, a lot of the publication that you see is from single institution trials. So this is our trial that we call a quality of life study. We treated 423 patients between 75.6 to 78, we'll call Koval equivalent. That's really just gray at 1.8 to 2 gray per fraction. The median follow was approximately 5 years. The biochemical failure rate in this study was 5.2%. So the biochemical freedom was 94.8%. With the overall survival at 99.8%. If you look at grade 2 or higher toxicity, grade 2 GI was 9.7%, grade 2 GU was 15.9%. There was no grade 3 GU toxicity. There was one grade 3 GI toxicity, which I believe was rectal bleeding requiring a transfusion. This is actually the EPIC. So we actually had all the patients fill out EPIC questionnaires sort of before, during, and after treatment. So we're able to have quality of life data. And as you can see, there's very little difference in terms of the different domains in terms of before and after the treatment. As you can see, there is definitely some decrease in the urinary domain during the treatment, but afterwards the patients recover pretty nicely in terms of their symptoms. In terms of the overall satisfaction, this is like the last question on the EPIC questionnaire about how satisfied they were. 98% were either satisfied or extremely satisfied. So I think that patients did very well with the treatments. In terms of other data, I think University of Florida is the other group that publishes a lot in terms of proton data. This is their initial publication looking at 211 patients treated between 2006 and 2007 on 3 clinical trials. They all got between 78 to 82 Koval equivalent, treated at 2 CG per day. The definition of failure was the Phoenix definition. And their outcome in terms of freedom from failure was 99% for low risk, 99% for intermediate risk, and 76% for high risk. I think this is probably one of the better published data in terms of, once again, cure rates after radiation therapy. If you look at the actual 5-year toxicity rates using the CTCA version 3, for GI was 1.0%, and for GE was 5.4%. When they looked at the EPIC questionnaires, there was no significant difference between the baseline to the 4-year outcome, looking at bowel, urinary irritative or obstructive, and urinary incontinence scores or domains. They then published a couple years later a sort of, not really an update, but kind of looking at a larger group of patients who were not on study. So kind of really everybody. So this is more of a retrospective look. But it was a larger group of patients. So this is 1,327 patients treated between 2006 and 2010. So once again, similar doses, 78 to 82 Koval equivalent. And once again, their 5-year freedom from failure rate was 99% for low risk. The intermediate risk was a little bit lower. It was 94%, but the high risk is still about 74%. So that I think is relatively stable across the board in terms of high risk patients. If you look at their toxicity, they actually used a CTCA version 4 this time. For grade 3 GI was 0.6%. For grade 3 GU was 2.9%. And in terms of, once again, no significant changes in the urinary irritative or obstructive or urinary incontinence or bowel domains. There was some decrease in the sexual summary domain at 5 years in patients who did not get the androgen deprivation therapy. from 67 to 53. So I think there was slight difference in terms of the sexual function or the sexual domain, but overall patients did very well in terms of proton therapy. I think we talked a lot about hypofractionation. I think that's definitely a significant interest to pretty much all the people treating prostate cancer. So the University of Florida actually published their hypofractionation study back in 2017. So they treated roughly 320 patients with either 70 at 2.5 or 72.5 at 2.5, so either 28 or 29 fractions. So this is sort of moderate hypofractionation. They also had 5.2 years of median follow-up. And once again, the 5-year freedom from biochemical relate was 98.3% for low risk. It's a little bit lower for the intermediate risk, 92.7%. But I think that if you look at sort of the other study that's been sort of published today, I think it all seems relatively about 95% cure rate, which I'll go over in just a minute for our data. The cure rate, also, the toxicity rate was also pretty low, was 0.5% grade 3 GI and 1.7 grade 3 GU. We actually presented this at last year's ASTRO. This is actually by Dr. Stephen Frank, who's one of my colleagues here at MD Anderson. So this is our MD Anderson hypofractionation protocol. It's actually 55.5 at 3.7 CG per fraction. It's over 5 weeks. So it's actually 3 fractions per week, Monday, Wednesday, Friday. And this actually is slightly higher in terms of tumor EQD2. It's actually 82 gray versus 78 gray, which is our standard. But it's a little bit lower in terms of normal tissue toxicity of 74, assuming an alpha beta of 1.5 and 3 for prostate cancer and normal tissue respectively. In terms of the primary objective was incidence of grade 2 or higher GI toxicity at the 2-year treatment mark. These are our patient demographics. As you can see, most of the patients had T1C disease as well as Gleason 7 cancer. And about half of our patients got hormone therapy. And for us, hormone therapy for these patients consisted of Lupron for 4 to 6 months. We had the patients fill out EPIC questionnaires at baseline and usually every 6 to 12 months. And then we compare them between the baseline and the specific time point. And then we sort of define a clinical significant change from baseline as half of the baseline standard deviation. So if you look at sort of our data, and we treated 210 patients between 2013 and 2019 with 181 patients that were analyzed. We actually had a median follow of 2.6 years, which is fine. I think since we're just looking at toxicity, 95% patients reported no use of pads. We actually had about 3% using 1 pad per day and 2% using 2 pads per day. There was, I think, some change in the mean EPIC score for the bowel function, 93.9 versus 90.8, which I believe was not significant. In terms of the sexual function, there was no significant difference in terms of from baseline compared to afterwards, and same with the urinary function as well. If you look at the physician-reported outcome using the RTOG scale, I'm happy to say there was no grade 3 acute or chronic GU or GI toxicity, but the GU toxicity, which was grade 2, was 15%, and the GI was 4.8%. And if you look at the chronic GU and GI, it was 17% versus 5%, so pretty much close to the acute. And this is actually the sort of the toxicity, late toxicity, both GI and GU per time. As you can see, it kind of accumulates, and once again, so there's less GI than GU toxicity, which is very similar to what's seen with X-ray therapy as well. In terms of IMRT versus protons, I think that sort of currently there have been several retrospective comparisons have been published. I think that one that was published first that's kind of got the most press initially was the publication by Sheets et al., which showed that there was actually a lower rate of GI morbidity with IMRT using the SEER Medicare database. The problem I think with that study was that it's a SEER Medicare data, which is incomplete. So they defined GI morbidity as having any GI procedures, most often colonoscopy. And having talked to the people at Loma Linda, who was the only sort of proton center at the time in that database, they were telling me that they were having the patients do colonoscopies, even if they had very mild bleeding. So I think they artificially increased sort of GI morbidity based on this definition. So I think that it's an imperfect study to look at. I think better study to look at was Hoppe et al., which looked at a prospective QL study patients and compared them to IMRT patients who also filled out these QL study. And he actually found that more patients with IMRT had moderate to big problems with rectal urgency and frequent bowel movements compared to proton therapy. But once again, it is not a perfect comparison either. There's another publication by you, once again, showed slightly higher incidence of GU toxicity with IMRT at the 6-month mark after treatment using Serum Medicare database. But by 12 months, that sort of high incidence disappeared. There was no difference in GI toxicity. And then Fang et al., in fact, she actually was one of our residents, showed that there was no difference in acute or late G, grade 2 or higher GU and GI toxicity between IMRT and proton. So I think these have been very selective. I mean, they're all looking at retrospective data between IMRT and proton. So I think that once again, they're not as helpful as you want them to be. Currently, there is no randomized trial published to date. Currently, there is a randomized trial that's ongoing called Particle. That's the PI is at the Joint Center or Brigham and Women, Dana-Farber. So once again, that is still ongoing. That's going to be looking at the 2-year toxicity endpoint between IMRT and protons, and that is randomized, as I said. The other trial that we're looking at or waiting for the results for is COMPARE. COMPARE is actually a prospective comparison between photons and protons. In fact, here's the trial schema. So with IMRT, pretty much they can get any type of fractionation. We're looking at all risk groups, low, intermediate, and high risk. A very high risk group by the NCCN guidelines is not allowed on this trial. And we're going to sort of follow these patients. In fact, the goal is accrual is 1,500. And then these patients we followed every 6 months after the treatment with prospective quality of life EPIC. The patients getting protons could either do that, which is sort of a standard fractionation, which is 78. We're also trying to randomize these patients to the hyperfractionated arm, which is 60 and 20. So kind of the CHIP regimen, to see if we can get a prospective randomized trials to see both the efficacy and the safety of hyperfractionated proton therapy in these patients. So once again, we're trying to see if we can randomize these patients, 900 patients on the randomized arm of this trial. So once again, this is not a randomization between IMRT and protons. It is pretty much taking patients who are getting IMRT and comparing them to patients who are getting protons. But with the proton patients, we're trying to randomize to standard fractionation versus hyperfractionation. We're still accruing. In fact, we're accruing pretty well until the COVID-19 crisis hit. And unfortunately, the enrollment kind of dropped off the cliff. Thankfully, I think we're beginning to sort of see recovery, and I think we're definitely beginning to enroll patients again. So hopefully, within a couple of years, the data from this will be available. In terms of recent advances, I think that I suspect all of you are sort of incorporating more and more MRI into your daily practice. We actually have an MRI simulator, and we're actually using that more for the patients that are getting prostate treatment, especially the ones that get SpaceOAR. The SpaceOAR shows up very nicely on MRI compared to CT scan, so we're definitely using it for that. We're also sort of thinking for using for possible SIB for dominant lesions, but that's kind of work in progress. As you also, we use SpaceOAR a lot more than we used to. So this is a gel that we can put in between the rectum and the prostate to push the rectum away to decrease that dose. This is actually one of our patients who got the SpaceOAR. So this is an axial view. Here's the prostate. This is the rectum. And as you see, there's this sort of white structure on T2, which is the SpaceOAR. And in this case, it separates the prostate from the rectum by about 1.5 centimeters. So yeah, a huge separation. And when we did the actual plan for this, the V70 for the rectum was 0%. So once again, we can get these very low rectal doses with the SpaceOAR. So this is a sagittal view. Once again, here's the prostate. Here's the bladder. Here's the rectum with that coil. And once again, the SpaceOAR pushes that rectum away at least 1.5 centimeters from the prostate. This actually was the phase 3 trial that was published in terms of the SpaceOAR. And what it showed was that definitely decreases GI toxicity in terms of patients getting the SpaceOAR versus not. In terms of future directions, I think, once again, the SBRT was talked about. We're thinking about doing SBPT or stereotactic body proton therapy. And I think one of my colleagues is interested in sort of combine that with immunotherapy for higher risk patients. So I think that might be pretty interesting to look at. We're definitely trying to incorporate newer imaging modalities for both sort of staging and targeting. So the Axumin PET. I suppose you guys have the PSMA gallium PET. We don't have that yet, so we're going to hopefully get that soon. We're also looking at genomic testing. So I think we're going to, sort of decipher more and more for these patients to sort of tell us whether or not we should add hormone therapy to the treatment or not, especially for the intermediate group. And then I think that, obviously trying to incorporate newer systemic therapy like ABI or enzalutamide, immunotherapy with the radiation therapy for our patients. In terms of conclusions, so proton therapy is a safe and effective treatment for prostate cancer at this point that's at least as effective as X-ray therapy, shown by single institution trials. Although I think proton therapy does offer several theoretical advantages over X-ray therapy, I think there's been very limited clinical data to support these advantages. I think we've only been able to get retrospective comparisons between IMRT and protons. Therefore, we're currently waiting for the results of both particle and compare to really hopefully see if there's any difference between proton therapy and IMRT. In terms of who I consider for proton therapy, and this is very personal, so I think if you ask my colleagues the same question, they might give something a little bit different. So I tend to sort of think that for proton therapy, if I were to sort of hedge my bets a little bit, I definitely counsel probably younger patients to get protons, although once again, I don't have any data to support this. I mean, there is some data that maybe proton therapy does lead to less risk of secondary cancers compared to X-ray therapy, but it's retrospective data from Mass General. And I think it's not the strongest of data. So I think it's a little bit hard to sort of hang my hat on that. But once again, if I have a patient in their sort of early 60s or late 50s, I would consider giving proton therapy. Patients with history of lymphoma and leukemia with possible chemotherapy in the past or possibly in a bone marrow transplant, I definitely consider protons. I've done proton therapy also in patients with kidney transplants with a pelvic kidney. I think the proton therapy is kind of shines for stuff or situations like that. Once again, if a patient needs pelvic lymph node radiation, I definitely consider proton therapy over X-ray therapy. And I think anatomy-wise, I think if you have a very large prostate with a median lobe, one, I think you need to do proton therapy to minimize the dose to the rest of the bladder. Oftentimes, these patients are somewhat symptomatic from that median lobe, and so I usually have them get a TURP first, have them recover at least 6 to 8 weeks after that, preferably 8 weeks after that, and they may be fine getting IMRT after that. But once again, if the patients don't want to get a TURP or they're not that symptomatic and they get treated with a median lobe, I think the proton therapy does decrease the dose to the rest of the bladder because you're able to minimize the dose to the surrounding bladder tissue. So I think it probably does make sense to try and consider giving radiation therapy using protons in that situation. And I'll stop there, and I guess I'll take any questions at this point.
Thank you very much, Dr. Choi. So that was a wonderful talk by both of you. So we have a lot of questions coming in, and I think let's go, let's make our cameras visible so people can actually see us. Yeah, Dr. Choi, whenever you're ready, you can start your camera.
It says I can't start the video because your host has stopped it. Is that?
Oh God, I don't know this settings. Oh, wait, let me stop.
So try, but I couldn't do it. So here it is. My video. There you go. Can you see me okay?
Yes, now we can see you. Sorry. Perfect. So since we have a lot of questions, what I'll do is I'll probably just read out the questions because many of the participants are actually on telephone, so they may not be seeing us. So it would help if we, if I verbalize the question and ask, and both of you please answer them. So the first question is by Gaganpreet Singh. Is LQ model alone sufficient to predict the TCP? What is your opinion about LQL model for predicting biological response, the linear quadratic linear model?
So Gaganpreet, hi. I think that there's not a clear consensus on how the LQ model really works at high doses per fraction. And there are some other explanations. There's a very recent paper by Benzin and Vogelius, which look at how whether it's working in the higher doses per fraction or not, and they find that that at the high doses per fraction, the alpha beta ratio doesn't really hold true. So that kind of explains why in the trials that try to get better biochemical control by using ultra hypofractionation or moderate hypofractionation, they didn't really succeed. They didn't do worse than standard fractionation, but they didn't do better as expected. So one question is that we don't really know what the alpha beta ratio is at higher doses. I'm not really a radiobiologist. I can't really critique or really tell you a lot of detail about the linear quadratic linear model. I would just say that follow the clinical experience, follow the studies that are coming up, and see how they're doing in terms of choosing a dose fractionation for your patient. Dr. Choi, would you like?
I'm not a radiobiologist either. I guess my thought is, yeah, I think I was taught even when I was a resident that definitely at the higher doses, the linear quadratic model doesn't really work anymore. In fact, the doses are more than you think, because I think probably you have not only the DNA damage, but maybe the effect on the stroma as well. The other thing I always think about is I think I know that some of the clinical data supports it, but I think sometimes the patient's cancer may be aggressive enough that maybe a higher alpha beta ratio than you think. I think the one I usually talk about is the Fox Chase hypofractionation data, because I think the hypothesis of that data was to see if they can dose escalate using hypofractionation, and they did not get a improved control from the hypofractionation that expected. So if you read the actual, I think, conclusion, they thought that maybe the alpha beta is higher than the 1.5 for high risk prostate cancer. But I think in the end, I think definitely in terms of hypofractionation, I think moderate, I think is fairly safe. I get a little bit scared sometimes to use it for high risk patients where the alpha beta ratio might be higher than 1.5. As you said, and when you go with these higher doses per fraction, you may also have a hard time, estimating the effect too. So I think in the end, we've been using the moderate hypofractionation for the low, intermediate, and some high risk. But for the SBRT, we only really treat low and intermediate risk.
Yeah, in India, we have a lot of high risk patients, and we use, for example, in our hospital, and I think in Mumbai as well, in TMH in Mumbai, we would use moderate hypofractionation for every patient, and SBRT as well. And our clinical data is pretty encouraging. I think that we need to look at it for slightly longer to see how things are going. But so far, we as I mentioned to you, we have data. We have now median follow-up of 5 years for our initial cohort, and things look good. I think that in the higher Gleason scores, I think that whether it's standard fractionation or hypofractionation, you're probably going to get slightly worse outcomes. Yeah.
Thanks, Indranil. And it was wonderful for you to share your data, because while we as clinicians look at the data published all over the world, there's still that reluctance that we have in our mind that will this replicate in our Indian population. And your data was actually brilliant. It gives us a lot of encouragement in shifting in the moderate hyperfractionation direction. Next question we have from Nagarjuna, who's been my ex-colleague and a brilliant radiation oncologist at Proton Center in Chennai. He's asking, in the present era of modern image-guided proton therapy, can we avoid fiducials?
Yes, I think if you're using cone-beam CT for daily guidance, I think that's fine to avoid the fiducials. We actually use carbon fiducials at MD Anderson, so they cause less dose perturbation than the gold fiducials do. But when you look at the clinical outcomes of what's been published, I mean, I know that Florida uses gold, and their cure rate looks fine. So I think in the end, we may be making more of a deal about the dose perturbation than it actually really matters. So I think it's okay to use fiducials, but if you're gonna use cone-beam CT, I think that'd be okay.
Omar has asked a question: is it safe to include pelvic nodes when you do moderate hypofractionation? To a certain extent, we've answered that question, but yeah.
Yeah, I mean, we do elective nodal radiotherapy for all high-risk prostate cancer patients. As you know, that the data that we have from randomized controlled trials actually doesn't clearly support that. But I think there's interesting data coming up from the POPRT study in TMH. So I think so we are waiting for those results to be announced in ESTRO. But because it doesn't really add too much to the toxicity, we feel that it's okay. But it's perfectly okay if you didn't. Yeah.
What dose do you use Indranil in for lymph
I think
node?
that somebody else asked this question. So we use 44 gray in 20 fractions. It's really a dose which we tried to map up to, something close to 45, 46 gray in standard fractionation.
Okay.
And we often do SIB where the prostate is going at a higher dose, like 2.4 gray per day, and the pelvic lymph nodes be going at 1.8 to 2 gray per day. So in the end, I think we still use kind of conventional fractionation for the lymph nodes.
Yeah, we do SIB as well. Yeah.
My colleague Anand Jadhav has asked a very practical question. In case of machine breakdowns and natural calamities, such as all your staff turning positive on COVID, how many days gap of treatment should be considered for gap correction in hypo? We have a fair bit of idea about what happens when we have conventional fractionation, but when you have patients on hypofractionation, like I now we've started using hypo for the breast, the fast forward, and we had a 2-day machine breakdown in between, and it just went, we didn't know what to do.
So Dr. Choi, would you like to answer this question?
Yeah, I mean, the conventional thinking when I was treating patients with conventional was if you have to have a 5-day mistreatment, so this is a whole week that you can't treat, you add 1 fraction at the end. So that's kind of what our radiobiologist here came up with. I think if the patient is on hormone therapy, I haven't really done that. I think that as long as they're on ADT, I think that the chance of it, whether the repopulation, sort of overtakes the radiation therapy, I think is very slim. Now, if you're not any hormone therapy, you might consider that, but I haven't really added more because of, let's say, like a 1 or 2 day breakdown. We actually have a lot of holidays in the US that, like Thanksgiving or Christmas, where the patient is off treatment for like 3 or 4 days at a time. So I think it's still okay. And so, like I say, I usually don't do additional treatments unless it's a long period, which I probably define as at least a week or more. If it's like 1 or 2 treatments or days here and there, I think it'll be okay.
Yeah, I think that the data for the overall treatment time for prostate cancer, there are a couple of papers where I think that when they've looked at patients whose treatment got extended to about 10 weeks or 12 weeks, they found a slight detriment. Now, when you're hyperfractionating, you're basically finishing off the treatment in 4 weeks. So there's actually no data for whether 4 weeks versus 5 weeks makes a difference. So I mean, like Dr. Choi, I wouldn't do gap correction, and nearly 90% or more of our patients are on androgen deprivation therapy. So I don't believe that it really makes that much of a difference.
Plus, I think when you look at the SBRT data, we treat every other day for about a week and a half, but the Canadians treat once a week for 5 weeks. So, and I think they do just fine too. So, especially I think with hypofractionation, you could definitely give it a little bit of time for the break, and I think it'd be okay.
Okay. So next question is from Tushar. He's asking about volume delineation strategy. So basically, is there any difference between the delineation protocols for hypo versus conventional fractionation?
Not in my practice. I mean, I think that the only difference is in the PTV. So in the moderate hyperfractionation, I use a 7 millimeter PTV for the prostate, whereas in ultra hyperfractionation, I use a 5 millimeter PTV. But that is entirely, I mean, not based on any evidence. It is. We felt that because in the ultra hyperfractionation, we usually there's a physician present at the time of checking, so we felt slightly safer. But I don't believe that in any other situation it's a big deal. Yeah.
Yeah, I agree. I mean, the CTV is the same and the OAR is the same, but the PTV is a little bit different. So for us, the PTV for, let's say, IMRT or protons, usually 6 millimeters, all different, except for 4 millimeters posteriorly. For the SBRT, we do 5 and 3. So 5 millimeters all over and then 3 millimeters post.
I want to just bring back what Dr. Indranil mentioned before you went into the data, that we need to have good image guidance protocol, and the PTV margins ideally should be decided by each individual site. So while MD Anderson and Tara Medical are able to get away with 5 millimeter, can our center get away with 5 millimeter, or do we need 7 millimeter? Is something I think we need to look at our own data our own practices and determine. So this is one point where I definitely feel that we should not try to imitate the Center of Excellence and go by our own data.
Oh, that's definitely true. I agree with that too.
Anand again has asked a question, ki what is the rectal protocol that we are using? And Dr. Choi, I saw in some of your images, you had put a rectal balloon as well.
Yes.
So what is the policy in both the hospitals?
So for us, we try to have the bladder comfortably full, which is about 200 to 300 cc's. We actually have a bladder scanner on the machine, so we're able to measure the bladder filling every day, at least a kind of estimate. So we definitely try to have the patients have a full bladder. We ask them to drink either water or Gatorade or something to kind of get the bladder full about 30 minutes to 40 minutes before the treatment. The rectal volume, I think it depends. For a long time, we used to use the rectal balloon for all our proton patients. But since we are now using spacer for 90% of patients, I think that we stopped using the rectal balloon and the patients love it. And I think that once again, we sort of able to see whether or not the gas is, or the rectum has gas or not during the day by the KV imaging. We do ask the patients to avoid foods that can cause gas, like dairy products, as well as try to have a regular bowel movement per day, but we don't really try to make it too strict. And we definitely do not have them use an enema or, stool softeners or, laxatives. So I think, again, it's relatively lax in terms of how we ask to do it, but definitely the bladder, we have to have it comfortably full during treatment.
Yeah, in our case, for the bladder, we ask the patient to pass urine and then drink 500 ml and half an hour before treatment or scan. And in terms of the rectum, there's no real successful rectal protocol. So we basically follow some, similar guidance in terms of making sure the patient is not constipated. What we do really ensure is that the rectum is not full on the day of simulation. I think that introduces a systematic error. And we make sure that on the day of the CT simulation, they initially do just a few cuts of imaging to make sure that the rectum is the right volume before they take the actual scan. And because we do daily cone beam imaging, we usually, if we find that the rectum is distended for any reason, we usually don't treat. We ask the patient to get off, pass, stool or gas, and come back. And over the course of the last few years, our radiographers or technologists have become pretty good in determining who not to treat for the day or who not to who to not treat for that particular instance.
Yeah, and our therapists actually know now to use a rectal tube if there's a lot of gas in the rectum as well, so they'll sort of do that on their too.
Yeah.
We follow the exact same protocol, but in addition to that, we also, in most patients, start them on some sort of stool softener or laxative. And if the patient develops some sort of loose motion, then we stop it. And that seems to be sort of working with our patients. But I think the most important part here is the contribution of the therapist. Where are they able to detect that this is not treatable? And we're blessed that we have an excellent team who keeps a constant watch on patients' bladder and rectum volumes. Next patient is, what's your opinion on hyperfractionation in salvage radiotherapy by Ananda?
Do you mean salvage after prostatectomy? Is that the question?
I guess that sounds like that.
I've seen some abstracts at Astro looking at this question, including both moderate hypofractionation and SBRT doses, actually. And it looks encouraging, but I think it needs to be sort of looked at in a more robust fashion with a randomized trial. In fact, we have a randomized trial here at MD Anderson called HIPORT. It's looking at either our classic salvage regimen, which is 35 treatments, 70 gray, 2 gray per day, or we're actually looking at 23 fractions at 2.3 gray per day. So once again, we'll look at this hopefully in a randomized fashion and see if, once again, is this effective and have similar side effect profile as the conventional radiation therapy.
Yeah, in our case, about, I think, 3 years back, we started treating 55 gray in 20 fractions for the salvage treatment. That was based on, again, some abstracts that we saw earlier, and also looking at the schedule that the UK trial had in the randomized control trial, where they allowed 66 in 33 as well as 52.5 in 20 fractions. So 52.5 in 20 fractions is actually reported as a part of a randomized trial as an option. So in a situation like this, it would be reasonable. And I'd like to point out that the consensus recommendations actually want you to use 20 fractions. I'm not sure that many people will use it, but you can fall back on that if you really need.
So
And,
yeah, sorry.
Yes, Prasad. Yeah, please.
No, I was just saying that we have a lot of questions to go, so I might skip some of the questions which may be repetitive. Tapan has asked, why was CBCT performed in ultra short fractionation? I think, yeah, Indranil.
Yeah, I think he's asking why was CBCT done after the radiotherapy? Yeah, that's because we did the CBCT before the radiotherapy, and we wanted to know whether during that time the prostate moved or not, just because it was a part of a study of 30 patients. And in one of my slides, which I did not show, we found that the intrafraction overall motion of the prostate is very low. So that gave us the encouragement that we could actually implement this. The other way of looking at it is that you can also do, one imaging between arcs if you're doing ultra hyperfractionated arc therapy. But we were pretty happy with the results of the post imaging, which showed that the prostate hardly moved really.
Yeah, that's what we do. We actually do exact track between arcs, and the exact track is independent of the gantry, so you're able to sort of see what the fiduciaries are doing. And then if you really want to get high tech, we have an MR Linac that actually can image the prostate during the arc. So it's actually kind of neat to watch the prostate actually during the treatment and make sure it's not moving. So that's been very encouraging to, once again, as well, saying that with these high doses, it should be safe for the prostate.
And I think use of VMAT has completely changed the game for SBRT, because earlier we would take typically 40 minutes, 45 minutes for that, and we had to stop and do a scanning in between. Now the whole treatment is over in 2-3 minutes, and we also practice one before, of course, and one after. We also combine it with our surface guided radiotherapy. So it's interesting for us to sort of correlate surface guided radiation and then the post scan imaging as well. Sanjay has asked that, do you favor elective nodal radiation in high risk cohort, and do you favor boosting the lymph nodes?
For the node positives, we do boost the lymph nodes if they're residual nodes. So everybody starts with neoadjuvant hormonal therapy. So we usually do the radiotherapy between 3 to 6 months after the start of the ADT. If there are residual nodes that we can see on the CT planning, then we boost it to a dose of around 54 gray in 20 fractions, which is roughly around 66 gray. If it's very far away from the bowel, we sometimes boost to 60 gray in 20 fractions. Okay.
So what's your opinion on hypofractionation in salvage? I think we have taken that question, right? The salvage question.
It's a big question.
Yeah, what dose used for elective pelvic RT? That also I think Indranil has answered. Can you please clarify dose constraint in your institute? I'm sure Indranil will share that with us, and I will send an email to everyone tomorrow who had registered, and will all receive those. Omar has asked again, what indications they consider are correct to grant hypofractionated treatment to pelvis? Whether is it according to the Roche formula, or is there an evidence on the basis of lymph nodal involvement seen on the imaging?
Well, we do it for all high-risk patients, and of course, all node-positive patients. We don't use the Roche formula. We just wanted to keep it simple. Elective nodal radiotherapy isn't supported by a lot of evidence yet, so it's pretty much your practice kind of thing.
Dr. Choi, what is your take on this?
In treating the elective lymph nodes, I think they might also deal with a question that comes up later. We don't usually treat the pelvic lymph nodes electively in most patients. I think that, if you look at the RTOG 9413, end up being a negative study. So there's not much data for elective lymph nodes. I think in my personal practice, I think if I see a very high risk patient, like T3 plus Gleason 9 or higher, I would consider it. And I guess, but in those patients, I've been treating more conventional fractionation, or at least very moderate hypofractionation. We actually treat 30 fractions. And with that, I can usually treat the pelvic lymph nodes if I want to with a more conventional fractionation scheme.
Okay. So we have a very interesting question about delineation of urethra by Dr. Saurabh. Are we using MRI or is it on the basis of catheter?
If you-
Not delineate the urethra for my treatment plans. We haven't been really giving in the end, if you look at the plans that we have, it's a very homogeneous plan using VMAT or protons. And so at most, it's going to get about a 3 to 5% hotspot in the middle of the prostate. And with that, I haven't really seen significant urethral or urinary side effects. I guess if I was doing brachytherapy or maybe like an SBRT boost, I would consider doing that. But once again, for conventional or even moderate hyperfractionated, we haven't been doing that.
Yeah, we don't delineate the urethra. I think that we probably need to delineate if we do a single fraction SBRT in the future or something, but not in routine clinical practice.
And I think presence of catheter will complicate it because you will then have to ensure that the catheter is there when the treatment is also delivered. So you can't just have a catheter while planning and not have it when the treatment is delivered because the volume.
That's what I think Dr. Kupelian showed. I think he had a study where he put a catheter in, delineated the urethra, tried to spare the urethra with radiation, but he did not have it during treatment. And that study showed actually higher urethral toxicity, probably because they moved the hotspot away from the urethra with the catheter. But during the treatment without the catheter, the urethra went into the part that actually they moved the hotspot from. So I think once again, as long as you have a relatively homogeneous plan throughout the prostate, I think that it's fairly safe.
Great. So do you give CTV beyond prostate volume in moderate or ultra hypo?
You mean like, do I contour anything else? I sometimes do treat the proximal seminal vesicle with the prostate. But I think once you go to ultra hypofractionation or SBRT, I don't treat the proximal SV anymore. So for the moderate, I do. For the ultra hypo, I usually don't.
Yes, seminal vesicles we include for the high risk patients and partly for the intermediate risk patients. But I think that the question is, do we take a margin around the prostate? I think that's the question he's asking, and the answer that in my practice is no.
No.
So we spoke a lot about toxicities, and everything actually in prostate revolves around rectal toxicity because you don't want to see your patient, and especially for young radiation oncologists like this, we are going to be in practice for 20, 30 years. You don't want your prostate patient turning up 10 years later and blaming you for his bleeding rectum, which is highly likely. So what are the practical management consideration in acute rectal bleeding toxicity in moderate hypofractionation?
I have to admit, I usually don't see acute rectal bleeding toxicity from protons. I used to see it the most was from the rectal balloon, actually. So I think during treatment, it's very rare that patients are bleeding if they do not have a rectal balloon. And especially with the spacer now, I think that's even less likely. But I will usually manage it like a hemorrhoidal irritation. So I usually have them try to keep their stool soft and use either suppositories, that's, like Preparation H or Anisole if you have that in India, or if it doesn't really respond to that medication, I usually have them use a steroid suppository, and that seems to work pretty well.
So with rectal balloon, I feel that, you're actually, I don't know, it sounds counterintuitive because you're actually pushing the anterior wall of the rectum closer to the PTV.
Kind of, but I think what's happening with the balloon is as it's put in, it just irritates a hemorrhoid. So that tends to cause more rectal irritation and bleeding. You're right. I think one of the issues of the rectal balloon is that it really pushes the posterior aspect of the rectum away from the prostate, but that anterior rectal wall gets right next to what you're treating, and to get more consistent the dose every day. So I think there's both good and bad with the rectal balloon, but it does immobilize the prostate, which could be helpful in certain situations. And it can also push the sigmoid loop away from the prostate if it droops down. So there are definitely some patients where the rectal balloon is helpful. In fact, what I've been doing now is before I used to do one or the other, rectal balloon or spacer. In some patients, I've done both, and that seems to work pretty well too. So you can kind of get the best of both worlds. You get the spacer for the rectal sparing, and you get the rectal balloon for the immobilization plus the pushing up the sigma away from the prostate.
Okay. What's your opinion about, say, sucralfate enema or steroid enema as a preventive, not for treatment, but because
I have
there's some
to admit,
data.
it's not if the suppositories stop working, but they're kind of messy to use, especially the sucralfate enema. So my patients don't like it at all. I mean, we even had like something called Proctofoam, which is like kind of like steroid, but a foam. They hate that too because it's really messy. So I find that the enema, although is probably the least offensive in terms of use for the patient. So that's what I usually start off with.
Yeah. And so we have few more questions about lymph nodes. I think they have already been answered. And Tushar has asked, what is the dose rate that you are delivering, and will flash in combination with proton will be next popular choice? I think flash is the most talked about thing. I mean,
I have to
no
admit,
discussion is complete without flash.
we are working on flash. And as you know, this is where you give the dose within like a couple of seconds instead of actual a couple of minutes. And we're looking at that at the Proton Center. We can't deliver that dose yet, but I've been told that with the new center, we'll have that dose rate available. I'll be honest and say it scares me a lot. Although at least the preclinical data is very encouraging, the fact that it seems like cancer control is good and the actually normal tissue toxicity is actually less than with normal dose rates. But my thought is in the end is that I think I'm gonna probably do a lot of testing before I feel comfortable doing this to a patient, because in the end, I think thankfully we're able to now sort of measure the prostate location very easily with our onboard imaging, but trying to make sure that your target doesn't move within that first 2 to 3 seconds of giving the treatment, it makes me a little bit nervous about this whole thing. So yes, it's definitely hot right now, and I think every service is looking at it, including thoracic, but I'm going to sort of see what happens and so look at the data first before I treat anybody on this. So that's how I feel about it.
Yeah. Flash will also sort of rewrite the whole radiobiology, for us. And it's really interesting, and we'll wait for those results to come. Dr. Ajay has asked why moderate hypofractionation was not explored with proton at MDSCC.
Oh, we did. That was the 3.7 times 15. And now that study has closed, and we have sort of now said that for a patient to be treated with moderate hypofractionation, they have to go on that compare trial and be randomized to it. So we're not offering off trial to see if we can increase the accrual to that study. So we still do it, but it's only on trial on the compare trial.
Okay. The next question is on imaging, and Ruchir has asked, do you recommend include MRI images with CT images for marking the GTV? I want to go a little further than that, and at least in my practice, I don't even dare planning a prostate ablation without MRI. But do you recommend PET CT also, like a PSMA PET, to be included in this planning? Is there any role of that? And in MRI, which sort of sequences would you recommend? Would you practice?
You want to go first, or should I go ahead?
Go ahead, please.
So at MD Anderson, everybody gets an MRI when they walk through the door, pretty much Gleason 6s and higher. So they all get MRI scans. I think you can use different sequences since they're all multi-parametric, but I think we use the T2 the most. Obviously, I think the DWI is helpful. The contrast may be helpful. I think that's actually more helpful in the post-op patients, where you can look at contrast enhancement in the fossa as maybe indication that there is actually a residual mass there. In terms of GTV, we don't necessarily contour the GTV, but when I see, let's say, extra prostatic extension beyond the capsule or seminal vesicle involvement, I definitely use that information to kind of contour the CTV. So you can do one of two ways. You can contour your CTV to cover that, or you can be more generous with your PTV. I do think that you have to do something to cover that area more generously, so that once again, you have a little bit more of a margin in that location. That's how I use the MRI for.
Yeah, we use the diagnostic MRI. We don't fuse the MRI for planning, but we do use the information on the diagnostic MRI, that exactly as Dr. Choi mentioned, in order to make sure that we haven't missed an area. This is especially important for the T3, T4 patients that we get where there's apical disease. where that gives us an indication as to cover the apex properly. I think that's a very clear benefit. I think it makes sense to fuse, but I think that it's not as easy as it sounds. That's my opinion. Yeah.
Yeah, the problem is I think the MRI, the actual axis of the contour, the images are different than the actual axis of the CT images. So you have to rotate the images and it never does it correctly. So I think, yeah, I agree with you. I tend to use a diagnostic, but I look at it sort of side by side rather than using it formally. Back to your question of a PET CT or the newer PETs, we haven't been using it on a regular basis, mostly because insurance companies won't pay for staging with PET scans at this point. I think right now they're only really paying for the post-op patients with the rising PSA. But I think we do have a trial opening very soon looking at high-risk patients. I guess the real question is, how much are these going to really help us? Because if you see a very small lymph node in the pelvic lymph node region, I guess, do you go after it? I just don't know what that answer is. So I think we'll have to see what happens.
Yeah, PSMA PET CT is something that people love in India. I have a bit of a more philosophical viewpoint about it, exactly like you do. So I feel that, well, it definitely detects more disease. Whether it helps cure more patients, I really doubt. But I feel that I think that it's very poor in the primary. So I wouldn't use it for any radiotherapy treatment planning in terms of the primary disease or the disease inside the prostate. But if there are specks of disease in lymph nodes, I think that by the time you've given them 3 to 6 months of ADT, those nodes are gone, and then I wouldn't use them at all.
Yeah, absolutely. Shravana has asked a couple of times one question regarding gating. So are you both using gating? Do you feel it is useful? Is there any role of gating in prostate therapy?
So we actually are now using the MR-Linac in terms of being able to visualize the prostate using a sort of cine mode MRI during treatment. And it does not move significantly with respiration. So I think gating is not necessary for the pelvis, at least not for prostate.
Yeah, we don't have any facility for gating, so we don't use it.
And we've looked at our data with surface guidance, and it doesn't move that much with respiration. You don't really need to monitor that. And with RapidArc and VMAT, again, the treatment time is so short that it's pretty quick. It's not going to take half an hour, 40 minutes. My dear colleague Sanket, very pragmatic man, has asked a question. If we consider hypofractionation, what's the preferred immobilization that we use? And especially in ultra hypo.
Knee rest, that's all. That's what I have.
Yeah,
I don't think there's any evidence for any external immobilization.
We just use a cradle for their legs.
Yeah.
So we use a knee rest in combination with an ankle rest, and it perfectly locks the pelvis, and it's just wonderful.
Yeah, I agree with you. I think that's a very, very good thing to do.
Arun has asked, what's the best volume treated by IMRT and proton in terms of best treated by switchover? So in terms of CC, best treated by therapy, how can practically switch over to prostate brachytherapy to a case? I'm sorry, I didn't really understand the question, but I think it's referring to brachytherapy. What's the best volume to be treated by IMRT and proton? So I'm not sure.
I can see that, like with any of the treatments that we do, smaller the better usually. I think that I don't do brachy anymore, but I think with brachytherapy, a lot of people talk about 60 cc's, although it totally depends on the pubic arch interference. Obviously, you may have a very small prostate like 30 cc's and still can't do brachytherapy because of that. But I think around 60, maybe even 70, you'll definitely run into pubic arch interference much more consistently. So I think beyond that, it'd be very hard to do brachytherapy. External beam, I think, I've treated, as large as 120 cc's. But I think that once again, usually for me, like smaller the better. And so a lot of times these patients may require androgen deprivation therapy just for reducing the size of the prostate before the radiation is given. If it's too large, I usually have them just get surgery. That might be just better.
In India, unfortunately, we see a lot of advanced stage tumors. So, very few people are using brachytherapy because very few patients are eligible for brachytherapy. In Mumbai, I think Hinduja Hospital is the only hospital which is doing brachytherapy for prostate cancer.
I think it's a great treatment, by the way. So
Yeah, for
and
early
I
stage, definitely.
think it's great.
Mohammed has asked a question which I am very curious about is, are there any complications that you notice with spacer? Because we tried to sort of think in those lines and I got a little, jittery around it. At the end of the day, it's an invasive procedure and you need a radiologist who's trained and really good with that. So
There are radiologists or urologists. So I think, some of our urologists are doing it as well. And I think, definitely some of the private practice are doing it. I think obviously with anything that's invasive, there's a risk of infection and bleeding, although the risk of infection should be pretty low because you're doing a transperineal insertion, not a transrectal insertion. The other thing I've sort of heard about is potentially having the spacer infiltrate the rectal mucosa. I think that's been reported, but it's a very low risk. I think when you first place the needle to do the spacer replacement, you're supposed to use water to kind of hydrodissect first. So hopefully, that chance of you actually putting the needle into the rectum and doing that should be fairly low, but it has been reported. I think it's like less than 0.03%, so it's pretty low, but that's been reported. I mean, the biggest thing that we worry about spacer is that in patients with T3 or T4 disease that's posterior, that the spacer may push the cancer away from the prostate into, next to the rectum. So in patients with bulky T3 or T4 disease, we don't do the spacer for that reason, but that's really it. All the patients I've had so far who got the spacer, they've done really well. So I think that I'm happy to say it seems like it's pretty well tolerated.
Okay.
Oh, they do get some sensation of pressure in the rectal area for the first day or two. Like they almost have to have a bowel movement, but in the end, that goes away with time.
Okay. There's a question from Karthikeyan about managing intrafraction prostate motion during proton therapy, and I think that would go well for Intranil also during photon. What do you do anything, or do you feel we should do anything?
Yeah, I mean, I think, my feeling is that, I have to admit, when we did the balloon and everybody, there was no intrafractional motion, thankfully. Now that we're using spacer more and less of the balloon, I think we might need to sort of revisit that issue. In the patients I've sort of seen or sort of done sort of verification CT scans in between, they seem to not have significant movement. In the end, if you think about what's really causing the prostate motion, is usually one of two things. Most common, it's the rectal filling, so gas or stool, or sometimes the bladder filling. So we try to kind of correct for both of those. So we definitely try to have consistent bladder filling, and the rectal filling, as we sort of talked about, try to avoid gassy foods. And if there's gas, then my therapist would go in and take, use a tube to do that. And so I think as long as you can control those two things, the chance of intrafractional motion, I think, is pretty low. And as you said, the treatments are getting faster and faster. So now, as you saw with the protons, with one beam, it takes less than a minute. So even if you did two beams, it'd be like about 2 minutes or 3 minutes of treatment. So the amount of time that the patient will get treated is very short, to the point that, once again, intrafractional motion is probably less of an issue.
So Nagarjuna wants to know what is the selection criteria for ultra hypo in proton? Which patients are you selecting?
No, we haven't done any yet. I think, so we actually have so as you probably know, we have our proton center opened in 2006. We have a new center going up right now that'll be, I think, ready to go in 2021 or 2022. We do not have cone beam CT available. So I think that in the end, we're not doing SBPT for that reason. I guess if we use sort of the SBRT criteria we're using for x-rays, it's been sort of low and intermediate risk. I think we can probably also, in fact, our criteria was changed recently to allow for low volume, high risk as well. So I would not do the very high risk, like Gleason 9 or higher. But I think Gleason 8, I think, is okay, especially if the PSA is less than 20. So I think those are the ones I would sort of suggest treating. Low risk, intermediate risk, both favorable and unfavorable, and probably low volume, kind of what I call favorable high risk, Gleason 8.
Okay, great. So Dipanjan Mazumdar has asked another explosive question, which many of us have in our mind. If proton and photon is equivalent, then why bother with proton?
I think, part of it has been is the fact that, it's kind of well, let me go back. I think, in the end, you're right. I think if you do IMRT or VMAT very well, the patients tend to do very well too. And I think part of it is that with proton therapy, I think the reason why the prostate cancer patients were treated with the proton therapy was because of the fact that it's very prevalent. and we could definitely have a lot of patient population with the prostate cancer. The other thing I think is even if the VMAT is good, I think that, you know, theoretically we're now treating other indications for prostate cancer, as I said, sort of these post-op patients, as well as pelvic lymph node patients. So I think our goal at this point is like, can we also improve the patient's outcome for those? Because as you saw, the high risk tend to still have a pretty high chance of failure. So if you look, I mean, if you look at the low risk and intermediate risk cure rates, it's 95 to 99% with protons and probably IMRT as well. So I think, again, I don't think we'll make that much of a difference in terms of IMRT or protons for the low and intermediate risk. But I think where we may have more of a benefit is really the high risk patients, maybe the very high risk, as well as the pelvic lymph node cases, because I think that once again, there is some data that suggests that protons may have a higher RBE, or relative biological effectiveness, especially where the Bragg peak is. And with the pencil beam, we're able to kind of deposit those in the higher RBE in the areas of gross disease. So once again, if you're able to delineate now better the actual GTV, so we sort of talked about this a little bit, we don't do it now, but if you do go to a point where you actually can delineate the GTV in the prostate and give that a higher dose with a higher RBE, that might be helpful in getting better local control. And this is where I guess, you know, all the different prostate treatments kind of come together, because I think we now know that dose escalation and maybe boosting the prostate may be helpful. So if you look at the ASCEND-RT data and again, brachytherapy boost, giving a higher dose to prostate seems to be helpful in these high-risk patients. So I think that whether we do that with brachy versus SBRT versus protons, I think that's where we sort of need to go. And I think that's where the proton therapy will be beneficial in being able to give that higher dose. And as I said, in the lymph nodes, I think it's a huge difference. I mean, it's really anecdotal at this point, but I think that definitely patients who get proton therapy for their pelvic lymph nodes do better than the ones who get IMRT, at least in my experience. And I guess the real question is, in the kind of the era, and this maybe not for prostate cancer in general, because prostate cancer may be an immunocold tumor, but if you need to have, let's say, a GYN cancer patient or bladder cancer patient, and you treat the pelvic lymph nodes along with the, let's say, the tumor, and you want to give immunotherapy or kind of still decrease the immunosuppression or lymphocyte depletion, I think the proton therapy may have a role there too. So I think once again, if you're really just talking about definitive prostates and local to the prostate only, you're right, there may not be that much of a benefit. But once again, I think that it kind of is a stepping stone to kind of a larger treatment of the pelvis and maybe other sites in the pelvis as well. So I think I gave a very long-winded answer to a very simple question, I know, but I think that's kind of where I think about protons in general for prostate cancer or GU malignancies in the pelvis. Hopefully that actually was okay.
The context in India is, Dr. Choi, the insurance doesn't cover it, and it's pretty expensive compared to the photon. So it's basically currently a luxury. It's the Louis Vuitton of radiotherapy in India. So
let me say this. I think going forward, I think for at least the US and maybe in other countries too, this will be adopted. I think there's definitely talk about lump or, you know, one payment for any treatments. So whether you get brachytherapy or IMRT or protons, in fact, some of the proton centers actually will get paid the same for IMRT versus protons. They're getting the same reimbursement. So once again, I think that, you know, if the cost issue goes away, I still think the proton therapy has a lot of advantages. So I think that once again, but that's a huge if, I understand. But I think that once again, if it can at least in this country, I think we'll go to a point where I think that both protons and IMRT will be the same cost at some point, and it's gonna be pretty soon.
Indralil, any thoughts from you on this?
Yeah, I mean, I think that the benefits of proton over photons are probably marginal in prostate cancer, and there will be individuals who will benefit from proton therapy because of you know, what the proton therapy really does, I think, is it reduces the low dose levels in the rectum and in the pelvis, especially when lymph nodes are being treated. Whether that translates into clinical benefit or not, I think that we probably need studies to show that. And I'm really keen to see what the two studies that Dr. Choi mentioned show. I mean, I wouldn't think that proton has a very, very large advantage over photons in prostate cancer. But I think that we need to wait for, you know, comparative studies.
Thank you. On that note, I think we'll wind up. Interesting statistics is we had 180 people at the beginning, and still 90 people after almost 2 hours of this discussion are here. And that just tells us what an excellent webinar this has been. And it's awesome to see, to hear from both of you on these issues. And thank you very much for both of you to join here, and especially Dr. Choi to get up that early in the morning and join us and share your experience. Thank you. And Indranil, you've been a very good friend, and it's just wonderful to see, people with whom I have worked to do the things that you're doing. We have Tara Memorial Hospital in India, which is a beacon of oncology in India, and the Tara Medical Center is now our next hope, and we are really happy to see the data that is coming out of Tara Medical Center. So thank you very much for
Thank
both
you.
of you to
Thank
join. For all the participants, we will be sharing some of the resources about what we discussed today, and I'll send you the email very soon. Thank you very much, and have a good evening and good night and a good weekend. And have a good day, Dr. Choi. Thank you very much for joining. Bye-bye.
Bye.